Though the topic is on diabetes, I'm mainly going to talk about insulin. So because you all know about diabetes, but the problem is insulin and the types of insulin. So I think as junior doctors, you should be having enough knowledge of how to manage the insulin, what types of insulin, what are the complications. So I'm trying to give you some sort of insight into it. So I will briefly sort of go through differences between type 1 and type 2 diabetes, summarize types of insulin and insulin safety and how to prescribe them, and then hypo and hyperglycemia. So type 1, traditionally we know that it's diagnosed in childhood. It's absolute insulin deficiency, but it doesn't mean that adults cannot have type 1 diabetes. Sometimes you can even diagnose type 1 diabetes at the age of 70, but if you would suspect type 1 diabetes if a patient is presenting with significant weight loss, and sometimes they might present with DKA or some amount of ketones, and so even if it's an adult, you would suspect type 1 diabetes. In that case, you would do antibodies like GAD antibody, zinc transport 8 antibody, and sometimes you would do islet cell 1 antigen antibody. And then also you would do urine C-peptide to creatinine ratio. If it is low, that tells us there is no insulin production or minimal insulin production, but you must be very careful. In type 1, you can still have some insulin production. So you can have some amount of C-peptide still remaining in the system. Type 2, it's mainly adult onset and usually associated with obesity, or they may be of normal weight sometimes. It's associated with insulin resistance. I'm not talking about MODY. MODY is very, only a very small percentage of people will have MODY. So I'm just skipping MODY. It's too technical to go into that. And then type 3C is the pancreatic diabetes, and then gestational diabetes. These are the most important types. And in type 1 and type 3C, insulin sensitivity is normal. Insulin sensitivity is normal. Therefore, you must be very careful giving high doses of insulin at the beginning, immediately starting on high dose of insulin. But sometimes in type 2, you would need high doses of insulin because insulin resistance is there. And type 3 also, they have no insulin resistance. It's because of pancreatic problems. So if you look at prevalence of diabetes in inpatients, 1 in 6 hospitalized patients have diabetes. So 1 in 6 in the hospital would have diabetes. And 35% of them will be on insulin. And 18% would have experienced some sort of prescribing error of insulin. So that's very, very high. And then 1 in 25 with diabetes have developed DKA whilst they are in the hospital. So they get admitted for some other reason, say for surgery or a fall or an infection. And then because we don't make appropriate decisions and appropriate prescriptions, people go into DKA whilst in the hospital. So that's why learning about insulin is important. So I will start with some errors of insulin prescriptions. So these are just a few sort of examples. So patient with type 1 admitted to ED following paracetamol overdose, insulin not given whilst in ED, and patient developed DKA. It's not uncommon, because sometimes the ED would have only ectropid, nothing else. So if the patient comes with, say, Novorapid, patient hasn't brought anything, that patient will be there for hours and hours without any insulin. And then another scenario is patient, these are real stories. Patient on a surgical ward with type 1 diabetes developed DKA due to insulin omission. So DKA patient transferred to the surgical ward, and patient recovering, now eating and drinking, intravenous insulin stopped. And then no further sort of monitoring or actions taken, patient goes into DKA again. And then patient had a cardiac arrest following severe hypoglycemia due to insulin dose being given twice. It happens a lot because the patients, they bring their own insulin. They normally inject their own insulin. So they inject the insulin. Patient got his own insulin. And then the nurse also gave the insulin, so double dose. I was doing an investigation recently. A mother brought her daughter with learning difficulties to the hospital, and the ED doctor noted the mother was drunk, and she brought an insulin pen and said she's using 60 units of this insulin. So the night doctor couldn't find anywhere, so he only had this information. So the night doctor in EAU prescribed 60 units. In the morning, she went into hypo to see that this lady has brought her husband's insulin. So we must be very careful in prescribing insulin. And the other classic example is the fourth one. Patient given 64 units of insulin, but originally the patient was on 6 units. The doctor prescribed as 6U, but that U was looking like a 4, so the patient was given 64 units. So when you are prescribing insulin, you should, in the insulin prescription card, you don't need to put units. It's an insulin prescription card. You don't prescribe in milligrams or grams. It's always units. So you don't need to mention U. You can say 20. That's all. But if you're writing in the notes, you write as 6 units, not U. 6 units. Otherwise, this can happen to anybody. So most insulin errors are wrong doses. Like I said, for units, you put a U and then somebody takes it as a 0 or a 4. And then failure to adjust insulin dose appropriately in response to hypo or hyperglycemia. So if the patient is having hyper or hypo, you should appropriately adjust it. That's why I said you should know about insulin, you should know about what you're doing. Insulin infusion, sort of setting an infusion can, like, if you're not experienced, it can sort of cause errors, but, it's mainly from nursing side. And then omitted or delayed insulin, like insulin not prescribed or stopped, administered on admission. Yesterday, I had a situation where the patient is on Humalog and insulin prescribed 3 times daily. And I'm seeing the patient that he came with hypoglycemia, I think. Yeah. So patient came with hypoglycemia. Patient was normal glucose in the morning. Patient was prescribed normal insulin regime. Humalog, I think 12 units 3 times daily. And then the morning dose was not given. And then lunchtime dose was also not given. When I saw the patient, the blood sugar was 20. When we asked from the nurse, we were told we don't have Humalog, we have only Novorapid. So as doctors, we should know that Novorapid and Humalog could be interchanged. They are very similar, though not the same, it's similar. So we should have told the nurse in the morning itself, or the nurse should have highlighted it. We should have prescribed Novorapid in place of Humalog. So in some patients, when you say nil by mouth, people sometimes stop insulin as well. You don't need to do that. And then, but you need to adjust the dosage according to maybe lower dose or only the basal insulin, something. Insulin not administered at correct time in relation to meals. Sometimes, if the patient is injecting, they know that a short-acting insulin should be injected about 20 minutes before meals. and at least 15 minutes before meals. If the insulin is given in incorrect times, then people can go into hypers and hypos. So insulin inappropriately omitted following a treatment of hypoglycemia. Sometimes, you treat hypoglycemia and completely stop insulin. Failure to supply correct insulin preparation or device. I will be showing you the devices and the types of insulin, so you would be familiar with it. And then wrong insulin products. So when it comes to insulin products, you must be very careful. We always, when it comes to insulin, we always prescribe by brand names, not generics. So we advise for all other medications to be prescribed in generics, but in insulin, we advise people to prescribe in brands because, insulin is brand specific. And sometimes insulins can be looking very similar, sounding similar, like Humalog Mix 25, Mix 50, everything is Humalog. But Humalog, one is just a plain short-acting insulin, other one is mixed insulin. And then Nova Rapid and Nova Mix 30, Humulin I and Humulin S. So Humulin I is intermediate acting. Humulin S is short-acting. So sometimes pens also look very similar. You must be careful when you're prescribing. And range of insulins. There are over 30 different insulin preparations, and many of these have differing actions but similar sounding names. This causes confusion to prescribers and those administering insulin and can lead to errors. And it can be quite harmful because it's not like you're prescribing metformin or glycoside. Can be quite harmful. So going into types of insulin, rapid-acting insulins, they are very fast onset within 30 minutes and then lasts only about 2 to 4 hours. And then short-acting insulins, intermediate, long-acting. And then there are some ultra-long-acting, like half-life of about 42 hours if you take degludec. And then pre-mixed is like Novamix 30, Humulin M3. Those are pre-mixed ones. So I'm going to give you a very brief idea about the duration of action. Fiasp is a new insulin, very new to the market, maybe about 2 years now. So it's a very fast acting one. It starts kicking off within 2 to 15 minutes. So generally it's given just before or after meals. So just before or after meals, you don't inject 15 minutes before meals. I'll show you a photo of it. This one, the one I'm showing here, I'm moving the cursor here. This is called Fiasp. So it's a blue pen with a yellow label. And then this is an American version. It's not Novolog, it's Novo Rapid. It's Aspart. So onset of action is about 15 minutes, peak in 45 minutes, and duration 3 to 5 hours. Humalog is similar to Novorapid. So Humalog, Novorapid, Epidra, these three are interchangeable. Interchangeable in the sense, like, if a patient comes to you, patient is on Epidra, you don't have Epidra in the hospital, but you have Novorapid, you can go for Novorapid. Patient comes with Humalog, you can go for Novorapid. So Novorapid, Humalog, and Epidra, all you can see that onset of action is about 15 minutes, peak is about 60 minutes, duration of action is about 3 to 5 hours. So it's all interchangeable. Even if the patient comes with Fiasp, you can do the same. So I'm showing you these photos because sometimes people will describe the pen rather than giving you the name. So this the first one is Fiasp. The second one is this is also Fiasp. This is Novorapid. This is Novorapid. and this is Humalog, and this is Epidra. So these are all short-acting ones. I would, ultra short-acting ones. These are, or rapid-acting ones. Fiasp is the fastest acting one, and more sort of naturally, more similar to natural one. So rapid-acting insulins will peak within about half an hour, and then last about 4 hours. It can last up to about 6 hours. And then short-acting ones, they take a minimum of half an hour to start acting, and then can last up to about 4 hours, sometimes up to about 6 hours, but it's usually about 4 hours. So Actrapid is the one we commonly use in the hospital. So this is Actrapid. This is Humulin S. No, this is M3. So I haven't shown a picture of, this is M3, but S also looks quite similar, a brownish color pen. And then Insuman Rapid and Hipurin Neutral. This is porcine insulin. Some people are still on porcine insulin. Some people would have been started about 40, 50 years ago, and then still they are on it. And sometimes it will be very difficult to get them. It's on special order. So this is the action profile of short-acting insulins. It takes about at least half an hour to start working, and then it will reach the peak by about 2 hours. And then at least it will be in the system for minimum of about 4 up to about 6, and then tailing off to about 8 hours. And then intermediate acting insulins, you wouldn't see a lot of prescriptions of these medications. Insulitard, Humulin I, Insuman Basal, and Hipurin Isophane. We used to call these insulin Isophane insulins. Insulitard and Humulin Insuman are human insulins. Hipurin is porcine. They act for about 12 hours. When you inject it, it takes a long time for them to have a peak. Ideally, we need a peakless insulin for basal insulin. So if you need an ideal basal insulin, you shouldn't have a peak. But in these insulins, you can see it's not a peak like a short-acting insulin, but still there is a peak. So these are also prone to give hypoglycemia. But generally, they work for about 12 hours. So usually, these insulins, Insulitard, Humulin I, Insuman Basal, or Hipurin Isophane, we would use twice a day. And with mealtime short-acting, with or without mealtime short-acting insulin. And then the long-acting ones, I have got some photos of the long-acting ones. I will show you as I go. There are mainly three long-acting ones. These are used in type 1 as basal insulin. As I told you, ideally you should have a flat peakless baseline. Levemir is, I would say, Levemir and Glargine are one of the oldest ones, or oldest ones. The Levemir works for about 16 to 18 hours. Lantus also about 18 hours. Tresiba is Degludec, is the longest acting one, half-life of about 42 hours, but it's given once a day. So all three insulins are given once a day. Sometimes some patients will be on twice a day Levemir or Lantus. Some people, depending on their glucose profile, we might have changed it to twice a day dose, but generally it's given once a day. These insulin are generally given as a basal insulin with short-acting 3 times a day or with every meal, or ultra short-acting ones. But some people with type 2 will be on these basal insulins once a day. So you might see in the ward, people are on either Levemir, Lantus, or Tresiba. But if the patient comes to you with a Tresiba, now you don't have Tresiba in the ward, you have only Lantus. Usually you will find Lantus in the ward, so you just replace with same dose. You can do that till the patient brings the insulin or is ordered from the pharmacy. So generally the profile is like this, and generally we say it's peakless, but still for Levemir and Lantus, you still get a slight peaking, but not as bad as the Humulin I or Hippurine Isofen, but there is a slight peaking, therefore there is a small risk of hypos. Degludec or Tresiba is peaking is less, and there is a new version of Glargine from the same company called Tijoyo. So the peaking effect is less with that, and it seemed to be giving less hypos. And then you get mixed ones. The popular mixed ones are Humulin M3 or 70-30. So 70% of intermediate acting and 30% short acting, or Novomix 30. Novomix 30 has got 70% intermediate acting and 30% ultra short acting or rapid acting. So the difference between Humulin M3 and Novomix 30 is Novomix 30 has got rapid acting 30%, and the Humulin M3 has got 30% short acting. So the rapid acting is Novorapid. So the mixture of Novorapid and an intermediate acting is called Novomix 30. So, but both could be used. Usually, if a patient is on this, it will be twice a day dosing. The patient will generally be a type 2 patient, not type 1 patient. And just out of the insulin, you would have seen people calling NIDDM and IDDM. Please don't use that term. It's not a classification. It's like, treatment-based classification, not accepted classification. So patients can be on insulin, but they can be type 2. So you would say type 2 diabetes on insulin, or insulin-treated type 2 diabetes. So call it type 2, type 1, or type 3C, or gestational diabetes. So there are various other combinations. I'm not going into detail. So these are the two pens you would see with patients. But some very few type 1 people also will have Novomix 30 or Humulin M3, because some people wouldn't want to take multiple doses and they will like it. And then sometimes on a personal sort of preference, they may be on these mixed insulins. So the mixed insulins will act like this. The rapid one will work like this, and the long-acting will work like this. Therefore, you give twice daily. So it doesn't cover your midday meal. So ideally, this patient would be eating a good meal in the morning and a good meal for supper. And then there are so many other mixed insulins. Humalog, as I said, Humalog is, I'm just going by the companies. Humalog is the rapid-acting insulin. So Fiasp, Humalog, and Norapid, Apidra, they are the rapid-acting ones. So Humalog Mix 25 and Humalog Mix 50 are similar to Novomix 30. So they are similar to Novomix 30, like this one. And then you can see, if you just come down, Humalog U100 and Humalog U200. So U200 means each milliliter has 200 units of insulin. And U100 means each milliliter has got 100 units of insulin. So this is more concentrated insulin. If you need, say, higher doses, a patient is taking 80 units of insulin for a meal, then you would prescribe Humalog U200 rather than U100. And then this Abesagla, I just wanted to show this. A lot of people will be on Abesagla. This is another form of glargine. So glargine comes in, Lantus is glargine, Tijoyo is glargine, Abesagla is also glargine. There's one more brand. And then from the Novo Nordisk, Fiasp is a really fast-acting, ultra-short-acting one. Ectropid is short-acting. Insulitard is intermediate-acting. Levemir is the long-acting one. Novomix 30 is 70-30 combination of intermediate and ultra-short-acting. And then Novorapid is the ultra-short-acting or rapid-acting. Tresiba is this one, the green one, green label with blue pen. Tresiba comes in U100 and U200. It's once daily, long-acting one. And you might see this one, Zultrophy. This is a combination of Tresiba and GLP-1 agonist called liraglutide. So you might see this combination. So just be aware that, people can come with various combinations of insulins and things. And this is heparin, you know that. And then Lantus and Tijoyo, these are long-acting ones. But Tijoyo is glargine, but the formulation is slightly changed. And therefore, the peaking effect is not there. It's slightly longer acting than the Lantus. So we tend to sort of change people to Tijoyo instead of Lantus and Levemir. Okay, so what are the non-analog and analog insulins? The non-analog insulins are human insulins mainly, or porcine insulin. It will mimic endogenously produced insulin and produced in a laboratory. And non-analog insulins are commonly used in type 2 diabetes. Analogs are mainly used in type 1 because in analogs we can easily manipulate. You can prolong the half-life, shorten the half-life, so you can make it act faster. So like Fiasp and Novorapid and Humalog. So we use it in type 1. But it doesn't mean that it's exclusive, that sometimes human insulins will be used in type 1. Sometimes analogs like, Novorapid, Fiasp and Tijoyo, Lantus can be used in type 2 as well. You would sometimes see type 2 people on basal bolus regime. Then insulin concentrated insulins. I showed you Humalog U200, and then Tijoyo comes in U300 and U100s. And then there is a particular format called U500 that's called Humulin R500. So that is very concentrated one. So these concentrated insulins should never be infused or put into an insulin pump. Shouldn't do that. Fine. So, and then biosimilars. Biosimilars means like glargine was originally produced by Sanofi, that's Lantus, but Abesagla was produced by Lilly, the same product, but not the original, so we call it biosimilar. They can be cheaper. I'm not going into details of insulin pump. When it comes to insulin pump, they can come with DKA, or sometimes they can just come with other illnesses. So if the pump patients come with intercurrent illness, pneumonia, or any other illness or a heart attack, they will be on a basal infusion and boluses for each meal. So the boluses will have to be increased depending on blood glucose. So sometimes patients would know what they normally do, or you might have to speak to the diabetes nurse at that point. I wouldn't advise you to sort of adjust the pump. And if the patient comes with DKA, you would stop the pump and start on infusion according to DKA protocol and give a basal sort of regime, like, either Lantus or Levami or whatever, a basal regime temporarily. And then next day you would contact the diabetes nurse and then sort it out. I will give these slides. You can find this video and go through this one. So when you're prescribing insulin, it's essential that it's prescribed for the right person, right insulin in brand, right concentration, right dose in the right time. And then in right device. Sometimes patients may be on a pen, maybe using a syringe. So you should find out which way they are using it. And then you should always write units rather than writing U or IU. Even don't use the term IU. So intravenous infusions, there are two types, continuous infusion and the variable infusions. So either VRI or FRI, that's fixed dose. The fixed dose is usually used in DKA or HHS, and VRI will be used in any hyperglycemia or patients recovering from DKA. So you would always mix the insulin in a 50 milliliter syringe with 49.5 ml of normal saline and 50 units of insulin. So then adjust your infusion rate according to the guideline. So when you're putting patients on DK protocol or VRI, that means variable dose, always prescribe your subcutaneous long-acting insulin. So if the patient is on glargine or Tresiba or Tijoy or whatever, you prescribe that. And then in VRI, always prescribe a substrate of glucose, 5% glucose, because otherwise patient is going to go into hypoglycemia, but not in DKA until you reach the point of 14 millimoles. So when you're starting on a variable rate, for the first 12 hours, you have to monitor every hour. So if they are stable, then every 2 hours. So first 12 hours should be every hourly monitoring. For DKA and HHS, use the trust guidelines. So we are going to review the trust guideline very soon, so it will be slightly changing. And then modified regimes are sometimes used in critical care, so that's not relevant to us. So this is the variable rate infusion chart you will find in guidelines. And then treating hypos when a patient is on IV insulin. So patient is on IV insulin. So when you are on an IV insulin, if you stop it, how long would it last in the system? I think it's there. It's about 5 minutes. But subcut insulin will last longer. So if a patient becomes hypoglycemic, that means less than 4 millimoles, whilst on IV insulin, whether it's fixed dose or variable rate dose, first stop the insulin, treat hypo, and then when blood sugar is more than 4 millimoles, restart insulin. But sometimes you might adjust the dose, but you would restart it, and then appropriate fluids. And just read this red one. Failure to restart IV insulin following discontinuation in a patient with type 1 could result in an episode of DKA, which can be fatal. So DKA patients, you might stop and put on a variable dose. The patient goes into hypo. If you just stop it, within the next few hours, patient would have gone into decay again. So you should restart after monitoring the blood glucose. So these are the important steps in stopping IV insulin. So stopping an IV infusion of insulin can be a high-risk procedure if not undertaken correctly, particularly for patients with type 1 diabetes who require insulin to remain well and to prevent DKA recurring. So in DKA, you must be very careful. So half-life of insulin is less than 5 minutes when you are giving infusion as an infusion. But subcut insulin can be absorbed slowly and half-life can be longer. But for an IV infusion, it's very short half-life. And then again, oral hypoglycemics, absorption can be delayed and half-life can be variable. And if you are stopping variable rate insulin, and if you are planning to start on the normal dose insulin, say the patient was on Lantus 30 units once a day and NovaRapid 12 units 3 times daily. Now you are going to stop the variable rate insulin. So give the NovaRapid about 30 minutes before you stop your IV infusion, because that is going to take time. The NovaRapid to kickstart is going to take time. So before stopping your IV infusion, start your normal insulin and then stop it. Take about 30 to 60 minutes. Whenever possible, continue your background insulin. So in most patients, you would need your background insulin, like long-acting basal insulin, to be continued. And you should remember the blood sugar control can be erratic for about 24 to 48 hours after stopping IV infusions, but you shouldn't be very worried about it. You should try and manipulate things and try to bring it back to normal, but you don't try to just jump back to variable rate insulin again. Then it will be a never-ending game. Like, you stop it, the blood sugar control become erratic, you go back, and it's very difficult. So managing a hyperglycemia, this is important in type 1, where the patient is, there is a risk of DKA if you don't properly treat hyperglycemia. So for a patient with diabetes who is unwell, you should always check ketones, pH and bicarbonate. So do a ketone and do a VBG. And if you want to exclude HHS, you should do osmolality as well. If it is a type 2, if you are suspecting HHS, do an osmolality. For patients with diabetes who are unwell, not eating and drinking, and DKA and HHS excluded, you can use variable rate insulin. For patients with diabetes who are hyperglycemic but remain well eating and drinking, DKA, DHS excluded, then you can use PRN short-acting, short or ultra-short-acting or rapid-acting insulins. I will briefly tell you how to do it. And then, regularly check your blood sugars, maybe hourly initially, and then adjust your insulin accordingly. In type 2, if a patient remains well and eating and drinking, hyperglycemia can be usually managed by altering regular treatment, like metformin, gliclazide, or whatever they are on. Okay, if you decide to give PRN, like, patient comes with hyperglycemia, patient is eating and drinking, not very unwell, blood sugar is high, say 25, you don't need variable rate insulin, then you can use PRN. Generally, you would use NovaRapid. In ED, they tend to use Actrapid. As I told you, Actrapid, the onset of action sometimes could be about an hour. sometimes even O when you give subcut. So it's better to give either Humalog, Fiasp or Novorapid. I would personally prefer Fiasp, but Fiasp is not freely available in the wards. Novorapid is available, so you can use Novorapid 2 to 6 units. How do you decide? So this is how you decide. So generally, not for everybody, generally for a person who is having a reasonable insulin sensitivity, 1 unit of Novorapid will bring down your blood glucose by 3 millimoles. So now you got a patient whose blood glucose is 24. You want to bring it down to 8. So what's the difference? It's 16 millimoles. So divide this 16 by 3 because each unit of insulin, Novorapid, is going to bring down your blood glucose by 3 millimoles. So divide by 3. 16 divided by 3 is 5. So 5 point something. So 5, I would take 5. I wouldn't take it as 6. So if it is, say, 17 millimoles higher, I would take it as 6. So divide by 3 and then give 5 units of insulin for this patient. So, and then when do you check your blood sugar? Do you check within an hour and give another dose? No. Here, when you are giving PRN, you would check after 2 hours. After 2 hours. And you would normally repeat another dose within 4 hours because you are not in a hurry. The patient is not very unwell. So you would wait for 4 hours. So you would check in 2 hours and then check in another 2 hours. And then after 4 hours, you might want to give another dose. And sometimes you will see type 1 people, they would know their correction doses. This is called correction dose. So they would know their correction ratio. Somebody will come and tell you, my correction ratio is 1 to 2 or 1 to 1. That means 1 to 1 means to bring down 1 millimole of blood glucose, you need 1 unit of Novorapid or Humalog. 1 to 2 means you need 1 unit of insulin to bring down 2 millimoles of blood glucose. So if a patient knows the correction dose for them, because it's individually variable, then you use that. Otherwise, you use the general sort of 1 to 3 ratio. That means 1 unit of Novorapid or Humalog, any ultra short-acting insulin to bring down 3 millimoles of blood glucose. So you can use 2 consecutive doses. You don't keep whacking the patient with correction doses. You use 2 doses. Patient is not responding, then go for variable rate insulin. So when increasing usual insulin doses, it is safer to increase the appropriate timed dose by 10%. If you are increasing, say the patient is on 10 units, it's safer to make it 11, but sometimes I would make it 12, depending on the situation. Okay, very important, this one, SGLT2 inhibitors. You would have seen medications called empagliflozin, dapagliflozin. Those are the common medications used in this country. You might see canagliflozin also. So rarely you can see patients coming with DKA with normal blood glucose when people are on these medications, because this particular medication, the EMPA and dapagliflozins, they work by inhibiting the SGLT2 receptors in the kidney. So they push the blood glucose through the urine. So you're passing lots of glucose through urine. So you can easily get dehydrated. So you are more prone to get diabetic ketoacidosis. Number 2, because you are pushing a lot of glucose through the urine and dehydrating the patient, if the patient goes into hypoinsulinemia or having intercurrent illness, they might have a blood glucose about 10 to 14, still going into DKA. So if a patient comes to you, patient is on canagliflozin, empagliflozin or dapagliflozin, patient is drowsy, looking very ill, check the ketones. And I have recently had to do an investigation on somebody who really arrested. The pH was 7 and arrested in the ward. She was on empagliflozin. So very careful on this. These are new medications, so you might see patients coming with this. So just read about empagliflozin and dapagliflozin. Then basics of good diabetes care in hospital. It's really important that you know which of your patients have diabetes and which of these are treated with insulin. So these are very, very important medications. You must be very careful in looking after them and prescribing. Ensure all medications are prescribed and ordered promptly and correctly. This will minimize delays in medication administration. So if you are not sure whether Humalog is not available, just discuss with the nurse and then prescribe something similar like Novorapid. Check the diabetes chart daily, blood sugars, insulin charts and things. Use insulin safely, take action when necessary. Check patient's feet and heels daily for pressure damage and ulceration, and feel the pulse in the feet. Talk to patients, family and carers and staff about insulin. Sometimes type 1 diabetes patients know their insulin better than you. So they might give you better information and it will be very straightforward. Sometimes the letters in the system may be wrong, because I would start a patient from the clinic on Lantus 30 units and Novorapid 6 units 3 times daily. In the coming weeks, the diabetes nurse will call the patient and they will keep increasing the dosage. The patient will be on 40 units of Lantus and maybe 15 units of Novorapid. So the patient would know better than the letters, like, the system may be not updated. So be very careful with that. Where appropriate, support your patients to administer their own insulin, but be very careful. We shouldn't be double dosing the patient, and speak up if there is a problem. So there are useful resources here. I will email this this presentation so everybody can look, and if you want more information, you can go through this. Any